Hello everyone, this video is specially for those enthusiastic medical professionals who don't like to blindly follow the medical orders given. They like to know the rationale behind each and everything that they are doing for their patients. Okay, why they have to do it, what happens if they do it, and what happens if they don't do it. Okay, the rationale, the logical basis behind their actions. It is very important for every medical professional to know what they are doing. Okay, so for example, we can say that when we take an axillary temperature, we have to add 1 degree to the temperature recorded. Why? We should not record blood pressure or do venipuncture or put an IV cannula on the arm with AV fistula. Why? We should not immediately rub or massage the site of IM injection. Why? In correction of hyperkalemia, we are giving insulin along with 25% dextrose. Why? For a patient with diabetes mellitus who requires regular insulin injection, we have to rotate the site. We should not give insulin on the same site every time. Why? Okay, so we have to know the rationales behind all this. We cannot just blindly follow it. So when you know the rationale, you can do it more confidently, more correctly, and also you will be able to explain it to your patient and the family members and the others. Okay, so my name is Shehnaz and let's discuss the rationale behind some of the nursing actions that we are doing in our daily practice. Okay, so before moving ahead, I would really appreciate that if you are new to my channel, please subscribe my channel, and if you find the content helpful, please do like and share my videos. Okay, so the first question: why should we add 1 degree to axillary temperature? See, when we record body temperature, okay, we record body temperature orally, axillary, tympanic, rectal and forehead. Okay, oral temperature we record it by putting the thermometer in the mouth, axillary by putting the thermometer in underarms, and tympanic by putting the thermometer in the ear, rectal through anus, and forehead, that is temporal. Okay, so there are different means, but among all this, oral, tympanic and rectal temperature are considered to be the most accurate readings of the actual body temperature. Okay, among all the 5, oral, tympanic and rectal temperatures are considered to be the most accurate reading of actual body temperature. And the average normal oral temperature is 98.6 degree Fahrenheit. And axillary temperature is usually 0.5 degree Fahrenheit to 1 degree Fahrenheit lower than oral body temperature. Okay, so that's the reason we are adding 1 degree to the axillary temperature that is recorded. For example, we recorded axillary temperature of a patient as the thermometer shows, say 99 degree Fahrenheit. Okay, so we add 1 degree to it and the temperature becomes 100 degree Fahrenheit. Okay, so this is how, because axillary temperature is usually 0.5 degree Fahrenheit to 1 degree Fahrenheit lower than the oral temperature. Okay, so that's the reason we are adding 1 degree to the recorded axillary temperature. Though oral temperature is more accurate, oral, tympanic and rectal, still most of the time we are checking axillary temperature because you know, in terms of safety and hygiene, axillary temperature is safe and good for all, especially for the kids. Okay, so that's the reason, because it is the most common means of checking the temperature, so we have to add 1 degree to it, to whatever the temperature that is recorded. Okay, hope I answered the question. Then the next question: why we should not check blood pressure on an arm with AV fistula? So as we all know that AV fistula stands for, as you can see here, it is arteriovenous fistula. Okay, so it is an irregular connection between an artery and a vein, okay, for dialysis purpose. Okay, it is a permanent vascular access for hemodialysis for patients with renal diseases. Okay, AV fistula is a vascular access for hemodialysis for patient with renal diseases. So we are not supposed to take blood pressure reading, we are not supposed to do take blood samples, we are not supposed to put a cannula on the arm with AV fistula, because this will interrupt the blood flow to your arm. Okay, if you do a venipuncture or put a cannula, it can cause infection. Okay, see, now when you're recording a blood pressure, we will put the BP cuff, okay, on the arm and will inflate it. So there is pressure exerted on the arm. So the pressure that the arm is under during the BP monitoring, with this pressure, the fistula can even rupture or tear. This will cause clotting and it can cause damage to the fistula, okay, because of the excessive pressure on the affected arm. So that's the reason we are not supposed to check blood pressure on the arm with AV fistula. So that's why you might have seen whenever we are checking a blood pressure, we receive a patient in ER or wherever, before checking the blood pressure, we look for if the patient is having a fistula on the hand. If the patient is having fistula on the hand, we feel it, right? We feel it by palpatory method. If the patient is having fistula, you can feel that thrill. Okay, you can feel that thrill or the pulse. Okay, and if the patient is having fistula on the hand, we are supposed to, usually they wear a band. Most of the patients, they wear a band on which it is written AV fistula. Okay, or otherwise some they write it on a piece of paper and they label it, so that the people are aware and by mistake they don't prick the hand or they don't check blood pressure on that arm. Okay, so as a medical professional, we should always check for the arm, feel the thrill. If the patient is having AV fistula on that particular arm, we should check the BP on the other arm, because it can cause clotting, it can cause damage, and the fistula may stop working. Okay, it can rupture or tear the fistula. That's the reason we should not record BP on the arm with AV fistula. Hope I answered. Okay, then next, why we should not rub or massage the site of IM injection immediately. Okay, see, whenever we take an IM injection, it is, the first instinct is that immediately we feel like we have an urge to rub or massage the site, and most of them, they believe that immediately massaging or rubbing the site of IM injection, it will reduce the pain temporarily and it will increase absorption. But actually it is not recommended. It is massaging or rubbing the site of IM injection immediately is not recommended, because this will reduce the efficacy of the medicine. How? Because when we are rubbing or massaging the site of injection, what will happen? The medicine, through the same way, it can it can come up in the subcutaneous tissue. Okay, and this will reduce the effect and the intention of the medication. So that's the reason we should not rub or massage the site of IM injection immediately. Instead, to reduce the pain, what we can do is we can just apply slight pressure with a cotton or with a gauze. If the patient is having pain or bleed from there, we can just put a slight pressure, gentle pressure, but not rub or massage. Okay, this can reduce the efficacy of the medicine. And if the patient is having more pain, they can apply cold compress also. Then the next rationale is why we should rotate the site for giving insulin injection to diabetes patients. For example, a person with diabetes requires regular insulin. Okay, so for such patient, we need to do site rotation, means rotate the site. We should not give insulin injection on the same site each time. We have to rotate the site with every injection, means we have to give injection at least 1 finger width away from the previous injection site. Why we have to do so? Because repeated injection in the same site, it can cause lipodystrophy. Okay, what it can cause? It can cause lipodystrophy, which is the most common dermatological complication in patients with diabetes on insulin therapy. Okay, lipodystrophy, may it be lipohypertrophy or lipoatrophy, whatever, it is nothing but it's a disorder of the adipose tissue, the fat tissue. Okay, where there is either loss of fat or abnormal distribution of the fat. Okay, so this complication can occur if we don't do site rotation or rotate the site of insulin injection. Fine, so that's the reason we are rotating the site. The most the best site for insulin injection is the belly, around the umbilicus. Yes, so we have to rotate the site. Okay, and once that is done, then you can go for the thigh, then you can go for the upper arm, and then after a few weeks, then again you can come back to the belly. So this how it has to be rotated. each time when you give insulin injection to avoid the complication called lipodystrophy in diabetes patient. Okay, hope it is understood. Then the last one, when a patient is having hyperkalemia is what? When the potassium levels are high in the blood, and we know that hyperkalemia, that is high potassium level, it is a life threatening condition, okay, which requires prompt management. It can cause dangerous arrhythmias, so that's the reason it has to be corrected immediately. Like for example, we have done an ABG, okay, then we found that the patient potassium levels are high, and then immediately we have to go for the potassium correction. So in case of hyperkalemia, the potassium correction, the first line of treatment for severe hyperkalemia, or the cornerstone or the mainstay of treating hyperkalemia, is what they do is they give insulin in 25% dextrose, okay, depending upon how much is the potassium level. What the doctors advise, like for example 10 units or 6 units of insulin in 25% dextrose, depending upon the level of the potassium, okay. So suppose say 10 units of insulin, human actrapid, is given in 25% dextrose. This will lower the serum potassium level by 1 MEQ per liter within 10 to 20 minutes, okay. So fine, okay, it is doing potassium correction, but why are we giving insulin with dextrose? Insulin is what we say, it can cause hypoglycemia, right? Insulin, though it can reduce the what we say, it has that it is a potassium shifting agent, we can say, okay. Insulin, what it does is, it is a potent stimulus of hypokalemia. It has a sparing potassium from urinary excretion by transporting it into the cells. What the insulin does is, insulin is a potassium shifting agent. By internalizing the potassium intracellularly, it reliably lowers the serum potassium levels, but it has a risk of hypoglycemia. Insulin, it can lower the potassium levels, as well as it can lower the blood glucose levels. So that's the reason what we are doing is, we are mixing insulin with 25% dextrose to protect the patient from going into severe hypoglycemia, okay. So insulin, it shifts the potassium into the cells by stimulating the activity of, or we can say that it activates sodium potassium ATPase, okay, which causes an electrogenic influx of potassium, okay, and it reduces serum potassium levels, but at the same time it can lower the blood glucose level, it can cause hypoglycemia. So that's the reason we are giving insulin along with 25% dextrose, so that the patient will not go into severe hypoglycemia. Okay, this is how we are doing potassium correction. So there are many such things that we are doing in our daily practice in the medical profession, that we should know the reason behind such things, okay, why we are doing it, okay, not just blindly following the orders that are written. Okay, so for more such exciting rationales, for more such exciting videos, please do subscribe the channel Nurses the Heart of Healthcare, and if you find the content helpful, easy to learn and understand, please do like and share my videos. And I strongly believe and recommend that a true medical professional should always be a lifelong learner, okay. Knowledge and skills, guys, please remember, knowledge and skills related to medicine, medical science is a blessing, and please use it for a good cause. We have to learn from each other, share the knowledge that we have with each other, and progress together, okay. So let's all grow together, progress together, and serve the humans, people in need. Thanks for watching, and thanks for all your love and attention. Stay connected with Nurses the Heart of Healthcare.